the other Craig had mentioned a study using an MDM2 inhibitor for 17p deleted myeloma. That, again, when people have 17, they have deletion of 17 chromosome, they don't have enough p53 to turn off the cells. And so MDM2 is a pill that makes you express more p53 so that the cells actually switch off. So that's one trial that we all have opened that we've been referring to. Also, I think that there is a lot of optimism that there are a lot of clinical trials really focusing on high-risk patients. That after, when we did the new staging system and saw what the 5-year survival was for each group, we really saw that for standard risk patients, there have been great achievements, but for the high-risk patients, we need to work a bit more. And so there's a lot of concentration on doing high-risk and doing research in high-risk patients. And I guess my last point would be that the one great thing about the antibodies is that the antibodies both that are here and coming on the pipeline appear to be high-risk agnostic. That a lot of high-risk is biological, while the external part of the cell doesn't really care.
And the other thing, honestly, we saw data that should give us optimism, right? The 414 translocation that we heard about in both of the first 2 lectures, that used to be high-risk disease, right? That was part of the definition that was on the list, along with deletion 17 and others, as high-risk disease. And it has shifted to more standard risk disease because we found the drug that eliminates that excess risk. Or doesn't, or proteasome inhibitors, right? So now that we've learned how to get rid of that excess risk, it's not high-risk disease anymore. And so that's proof that it's a question of finding the right drug. What's the mechanism, what's the problem, and hopefully targeting. I'm going to talk a little bit more about precision medicine also in my afternoon talk, so we'll get at that. It sounds like the real question is your myeloma starting to misbehave or not, right? Your numbers have worsened a little bit in terms of the protein numbers. The myeloma markers are worsening, but your other blood counts, not so much. And, I think this is the time when that starts happening and there's some uncertainty, restaging, repeating a bone marrow biopsy, repeating cytogenetic testing, repeating skeletal imaging if it's been a while since you've had it.
Yeah, I had that last week.
Good, because that's really important. One of the things that, a really common scenario, I'm going to talk about imaging later, but this wasn't one of the points in my talk, is somebody switches therapy, and then maybe they switch therapy again because it hasn't been working, and then somebody realizes that they haven't had skeletal imaging before either of those lines of therapy, and lo and behold, the next ray shows a bone lesion. And the difficult question is always, like, when did that develop? Did that develop before your current line of therapy, in which case we're treating it? Or is it developing on your current line of therapy, in which case it's not working and we need to move on to something else? And so being relatively up to date on restaging should not just be a bone marrow biopsy, should include skeletal imaging if it hasn't recently. So I think your doctor is handling things perfectly.
Now, on average, it's best for you to say, hey, this is just the protein to follow. If you really get specific, maybe IgA in a population of patients tends to be more chemotherapy resistant, but you yourself are not a population, you're just another Craig. So I would say, it doesn't really matter, it's just helping you figure out which protein to follow.
And then PET scan versus MRI.
I'm going to talk about that in my talk later.
Okay, thanks. And then one last thing is the smoldering multiple myeloma trials that are going on. It seems obviously more logical to try and get this before we start seeing damage to people. How many of those are going on, and how great have they been so far? And when do we start going back and getting the MGUS as well?
So there are actually more and more smoldering trials opening, especially after, as we get drugs that are less and less harmful. Because the one trick about smoldering is that not everybody who has smoldering is going to have myeloma. And so you take a risk of over-treating some people when you're treating smoldering myeloma. I mean, I think more than anything, what we need to have a reliable way to detect which smoldering patients will get myeloma, and then focus our trials on that population rather than knowing that we are going to over-treat somebody who may never ever have myeloma. And so there are a lot of trials for smoldering myeloma. They all contain molecular testing, and et cetera. And I think that's a really exciting area. For MGUS, that would even need to be more refined, because there's lots and lots and lots of people with MGUS. A minority of those become myeloma, and so you don't want to treat, you don't want to treat, millions of people where only a dozen or 100 may actually develop disease. And my question is, how are you or Craig with hair? We'll have to talk.
Speaking as a Greg, I think Craigs are overrated.
It can change. So as Craig had mentioned, and as I'll mention too, that there are different clones of disease, and people can develop novel mutations or new mutations as they go through therapy. So one possibility, one thing that does happen on occasion is that someone will not, at the time of diagnosis, they will not be 17p deleted. And then as they go through different therapies over the years, sometimes they can develop a 17p later. And so we do, when patients relapse, we usually do check the FISH testing and cytogenetic testing again to make sure that there are no surprises or changes.
I will counter that point, and I will argue that we do not usually. In my own practice, I don't usually. That would involve a bone marrow biopsy at the time of every progression, and I don't personally do that. At a certain point, because as Craig Hofmeister said, cytogenetic abnormalities are common at diagnosis, and they actually accumulate as disease goes. And so the likelihood of having high-risk disease by cytogenetic testing, when you have fourth-line therapy or fifth-line therapy or sixth-line therapy, is extremely high. But also, the behavior, your disease behavior is sort of defining itself in a way. Like it's, if you're on fifth-line therapy and you get 4 months out of a regimen and then have to switch, in a way, cytogenetics aren't informative. The fact that you had to switch therapy after 4 months is what's informative. The one exception, and we've been doing it at Hermanos, and all of our centers have been, which I'll talk about in more detail, is molecular profiling, which is different than cytogenetic testing. Cytogenetic testing is just looking for prognostic sort of factors, but molecular profiling is looking for predictive. I have that right? Predictive, something that predicts a response to a certain therapy because there's a certain molecular abnormality. You're screening for target. You're not screening for just sort of general, how's the weather? Does that make sense?
Okay, so if you do a bone marrow biopsy, which we do at diagnosis and at the time of initiation of a clinical trial, or if we're particularly interested in molecular profiling for a patient for which we have a clinical trial available. Bone marrow biopsy, you can get insurance coverage for karyotyping, which I think is useless. You can get coverage for FISH, staining with different mutations that are known to be prognostic, occasionally predictive for a particular treatment. And then you can apply and sometimes get coverage for molecular profiling with Foundation Medicine and other vendors that will test your bone marrow for a large panel of DNA mutations, much more so than the 5 or 10 that you do with standard fish. Who should do this testing? On average, we tell patients that if you're going to have a bone marrow biopsy and you already know you have myeloma, you should always go to the largest possible center that is available to you because there's less travel. Specifically, if you go to a large center, your myeloma aspirate goes from your bone marrow down the hall into the lab to do the testing. The most common reason for cytogenetics or molecular profiling, etc., to fail is because it had to travel a long way, often across the country, to a laboratory in ARUP in Pennsylvania, New York, wherever, and the plasma cells died along the way and weren't available for testing. And most of the time this is approved for standard genetics, and sometimes it's approved for molecular profiling. All our centers have molecular profiling clinical trials for which it's free to have much of the basic type of sequencing available.
Yes. Oh, but we all of us have the molecular. There's a clinical trial or a informational clinical trial where we're obtaining bone marrow biopsies, isolating the plasma cells, and then doing the molecular sequencing for 1,800 mutations that are known in cancer, and finding which one of those mutations are rare cancer at that particular time, and it's done usually for relapsed patients. There's a computer that then can match some of the findings to clinical trials that are around the world, and at some point we're going to hopefully have a trial that will match that to drugs that are in our research arsenal. But the molecular profiling, as of today, really is more informational than it is to have a specific therapeutic target for. There's the COMPASS trial, which is a widespread molecular profiling of newly diagnosed patients that is being done through the Myeloma Research Consortium, and actually is now expanded beyond the Myeloma Consortium to other hospitals, including VAs that are across the country. And that the information from that profiling is actually widely available. It isn't locked away, but is available on the web to researchers around the world to access. So, and as part of the COMPASS trial, that is true. That we participate with the VA.
Absolutely. And it's the case. Don't get political. It's the case because of how healthcare is administered and what is approved. And for a large portion of Western Europe, the access to the best available drugs was through clinical trial. And what is available off clinical trial was oftentimes not as good. In the US, currently, there is generally a principle of equipoise in that you have to believe that we have no clear data that what is on the clinical trial versus what's off the clinical trial, we can't know that it's better. That's why we're doing the trial, to see if it's better, right? This makes some sense. Whereas in Europe, that's often not the case. Often the best drugs are available on trial because of a lot of the healthcare administration. Enrollment of clinical trials in Europe for B-cell cancers and many other cancers is outstanding. And what I often like to say is that in the US, we probably have the cure for myeloma already. We just haven't had a chance to create the trial and enroll patients. Less than 5% of myeloma patients ever get offered a clinical trial. And it's primarily due to geographic and financial barriers related to our healthcare system.
And if I may take a speaker's prerogative and just add a little, I worked in the myeloma community in Europe for 7 years. And one of the reasons we do these types of meetings is that what I found in many of the European countries, especially the southern European countries, is there's a much greater authoritarian doctor-patient relationship. So the doctors don't necessarily educate the patients about the various options they have. They tell them, you will go into this clinical trial. And the patient says, yes, sir, or yes, ma'am. So there's a big, big difference there. So it's a cultural difference as well. And I think that also ties into the presentation that we'll hear right after lunch about what I was talking about before, about mid-thinking, about thinking with your disease.
So right now, molecular profiling is, sometimes it's being used to screen for a specific study, but this protocol that Craig mentioned is really, it's not linked to a specific clinical study. It's to provide the doctor and the patient with molecular information they would not otherwise have about their myeloma, to see if there is some unexpected target that you can go after. And so when do I do it? I start thinking about doing it around 4th or 5th line therapy. Because by 4th line therapy, for most patients, and it depends, right? So sometimes second line therapy is the same as first line therapy because they were on a 4-year break and it worked so well they just go back to it, right? And so it varies. But in general, I mean, once you've exhausted a couple of proteasome inhibitors and a couple of immunomodulatory drugs and steroids and a couple of alkylating agents and high-dose therapy and daratumumab and the other approved drugs, right? And once you've exhausted those and you are now at the off-label usage of lymphoma drug stage of your management, right? That's a very reasonable time to be thinking about looking for targets, thinking ahead to the next step. You know, it takes a little while to get those results back, and so sometimes as I'm starting something that I'm nervous about, I also do the molecular profiling so that I have my plan B already